Good afternoon, everybody, and I thank Dr. Giridhar for this opportunity to be speaking to you this afternoon. I have no financial interest. Now, when we are confronted with the situation of a cataract with diabetic macular edema, we have two jobs on hand. So the prevalence of cataract and diabetic macular edema, as we know, is related to a common factor, which is the duration of diabetes, and is also linked to poor glycemic control. And how does cataract affect our evaluation of the fundus? It degrades the fundus image quality by light scattering and also affects retinal measurements on the OCT. Now, coexisting retinal disease in the scenario of a cataract patient poses greater challenge to the surgeon. It's a riskier prospect for the patient. There is an impact of the extra disease burden in the retina, and it calls for changes in pre, peri, and post-operative routines. Now, we have been talking about the role of OCT, and it's almost, it has taken over the management of macular edema. Now, how does nuclear sclerosis and the various other types of cataract affect OCT images? Cataract in the form of a cortical cataract or a posterior subcapsular cataract affects OCT images much more than if it is just a nuclear sclerosis, because this absorbs the near infrared light but causes very minimal light scatter. So as a result, it is only the intensity of the back reflected light that is reduced, but it doesn't affect the beam itself. So you can get, as we shall see later in the talks, useful images on the OCT. The foveal contour is often discernible, and subtle additional changes can also be detected. Now, what are the issues involved in the management of cataract with diabetic macular edema? The diagnosis itself of diabetic macular edema through a cataractous lens would be difficult, as we had discussed earlier. So the indirect ophthalmoscope can be very useful to peer through the opacity. Slit lamp biomicroscopy and color fundus photography is a very useful tool to detect changes at the macula. Of course, ancillary tests like fluorescein angiography and OCT, if the clarity is reasonably good, can be resorted to. Examination of the other eye macular features are very important. And then we have issues related to treatment. What do we do? Do we treat with preoperative laser or anti-VEGF injections, or intraoperative treatments, or postoperative treatments? So we need to look at the natural history to decide on what to do. Now, untreated diabetic macular edema shows worsening, center involving one, often becomes irreversible in about 11% of patients who had no center involving macular edema progressed to center involving diabetic macular edema in the DRCR net. And this is due to the following changes that occurs within the eye: the movement of the vitreous due to the loss of the lens volume, and postoperative increase in the inflammatory mediators. Now, what are the cardinal issues? It is important to recognize that the patient has coexisting DME. It is no good if we operate on the patient without a semblance of discussion of the possible presence of macular changes and then refer him to a retinal surgeon, because the patient will then feel that you are coming up with an excuse, and he will always relate the non-improvement of vision to some problem in the surgery. Therefore, the pre-op informed consent has to be extended and adequate, and you must temper the patient's expectations. A cross-consultation with a vitreoretinal colleague is very important for a second voice of reason and caution. And of course, a holistic management to look at the patient's general health parameters is very, very important. So what are the current approaches to managing this patient? Phacoemulsification is the procedure of choice. I would say a caveat here: if the patient has a 4+ or a 5+, a very hard cataract with associated non-dilating pupils, etc., and you expect problems, there is no need to stand on ego and prestige. A very well done SICS may equally serve the purpose better. Intraoperative anti-VEGF or the steroids are the options when you have diagnosed preoperative diabetic macular edema. In the scenario of a recent post-PRP or a refractory diabetic macular edema, or if there's a troubled surgery, possibly steroids in the form of Ozurdex may be a useful option. And then, of course, post-op re-evaluation and treatment. Currently, there's no level 1 evidence for optimal treatment of diabetic macular edema prior to or after cataract surgery with any of the agents that are available. I remember an old saying about the treatment of bed sores. The saying was, you can put anything on a bed sore except the patient. So I would say you can put anything on the macular edema except more inflammatory mediators in the situation where you need cataract plus treatment. Now, these patients may look horrible to begin with, but many of these patients, when treated adequately, do reasonably well. That is, of course, the flow chart which suggests the management of diabetic macular edema post cataract surgery. Now, there are some unresolved issues. Now, pre-op NPDR, but no center-involving macular edema. Do we give anti-VEGF at conclusion of surgery as prophylaxis? There is no answer to that as yet, although some studies have found that it prevents the incidence of post-op macular edema. Dr. Giridhar will allude to that later. Now, if the patient has had a satisfactorily treated pre-op CSME, now it's important to continue the NSAIDs for longer. And some studies have found if the patient has had a concurrent PRP within the last 6 months, then the patient's developing macular edema is higher. So we may choose to defer or treat these patients with intravitreal long-acting steroids. I will just show a few photographs which I thought was relevant to this discussion. This patient was referred for evaluation of a vitreous hemorrhage of unknown etiology because the fundus changes were not commensurate with a PDR, but on FFA he did show a new vessel, and the other eye had a cataract. And if you look at this macula, it does show some degree of hyperfluorescence. I'm just trying to allude to the fact that there can be changes seen in the fluorescein angiogram even with significant degrees of cataract if you can't make it out clinically. This was another patient who came with cataract. He had been operated. The preoperative fluorescein angiogram was done elsewhere, and the postoperative vision was very poor, and on fluorescein angiogram, he had some distorted perifoveal capillary network. So in any patient with diabetes, it is always better to give a guarded prognosis. These are some of the other cases with non-center involving diabetic macular edemas. As I was telling you, the OCT can give you, although the signal is not too good, like it's probably signal to noise ratio is very high, but still you can see that the foveal contour is maintained and there are no intraretinal changes. This is another patient who preoperatively didn't seem to have much of macular edema, only hemorrhages there, but on OCT you find that there is an SMD with a lot of, this is diffuse diabetic macular edema that can often be missed. To add to the spectrum of problems already discussed, this was another patient who was taken up for, who was sent for a fundus opinion post-laser elsewhere, but he had something red at the macula, and on fluorescein angiogram, he had a leaking CNV, which was treated with anti-VEGFs. So there can be associated problems in addition to the diabetic macular edema itself. So just a couple of more slides. So cataract, we can subcategorize our management strategies into the following. Cataract with reasonably good fundus view, optimal management of diabetic macular edema first. You can defer cataract surgery till stability. The patient is in no great hurry. Only you should not be in a terrible hurry. Now, cataract with suboptimal fundus view, make all efforts to peer at the macula, explain to the patient that there is a possibility of subjacent problems, take help of ancillary tests, and intraoperative OCT, if you have access to some of the institutions, can utilize that technique as well. And cataract with no fundus view, of course, you always give a guarded prognosis and a B scan. So in conclusion, often cataract is not the only problem, but only part of a larger problem in patients with diabetes mellitus. In the presence of a macular problem, if the presence of the macular problem is identified pre-op, then it becomes the patient problem. Else, it becomes your problem. Thank you very much for your patience.